Hello everybody, so what I'd like to do is pick up where we left off from Tuesday's lecture. Now what you'll need to do for Thursday, since I'll be away this week, is watch these remaining lecture times that I have posted, the videos here for our screen capture. Review the corrected case study for endocrine that I posted on Blackboard for you. Correct your case study, make sure that you have the corrected version to use to study for your exam. And then work on your blog assignment that you have due after Thanksgiving break. Okay, so let's pick up where we left off with type 1 diabetes. Remember, when we're looking at type 1 diabetes, that is the kind where we have absolute insulin insufficiency. So the pancreas is not making insulin on its own. That means then that the glucose that floats around in your blood and your plasma needs to have insulin to be picked up and transported into cells. If we don't have sufficient insulin in type 1 diabetes, then the glucose never gets into our tissues like our muscles and our adipose tissue to be used for metabolism. So there's more remaining in our blood, and then our glucose levels become elevated, and our cells then don't get the carbs, the fat, the protein, and things that they need for energy. That means that people feel like they're hungry and they need more calories just because their cells aren't getting them, even though it's essentially floating around in their plasma still. So that results in polyphagia. The high glucose levels then that are in the fluid cause our cells to lose fluid. So remember, our fluid's going to shift to a higher concentration. So it's going to leave our cells and go into our circulatory volume, which means that our cells themselves are going to become dehydrated. That triggers our hypothalamus to think that we're thirsty and gives these clients that excessive thirst that they have. The excessive glucose that's around in our blood, our body needs to try and get rid of it. So that happens in our kidneys. Our kidneys tries to filter them, but they can't get all the sugar out. So what happens then is it spills over into the urine. And if we would test the urine of people who have diabetes that's uncontrolled, you actually find sugar in there. So that's the glycosuria that you get. And then the osmotic diuresis is what happens because that fluid is pulled out of the cells into our circulatory volume, and then we diurese to try and get rid of it, and that creates the excessive urination or polyurination that we see. So this video, whenever you're studying, is to help you understand how type 1 diabetes and body mechanisms work. You can follow that link in the PowerPoint presentation to make sure that you can review that and help you study. When we look at type 1 diabetes, what happens is that elevated blood glucose level leads to those signs that we get, that we just talked about, the increased thirst, the increased hunger, the increased urination. They're going to have weight loss and fatigue. Now, if their blood glucose climbs to an unsafe level, they're going to end up with metabolic acidosis. And one of the things we see with metabolic acidosis is this Kussmaul respiration. So they're very deep, labored breathing pattern that clients get when they're in a metabolic crisis. In this video below, you can watch it. It's actually an example of what you see in the breathing pattern that goes with Kussmaul respirations. You can actually smell that increased sugar on somebody's breath whenever their blood glucose levels are very high. So it gets a fruity smell to it. And then their blood concentration of their potassium is going to go down, so we'll see hypokalemia. Over time, what happens is all this damage, excess sugar, the acid-base imbalances, the changes in electrolytes is going to lead to vascular and neuropathy issues. And then whenever we look at what results of that, you can have cardiovascular problems, circulatory problems. And actually in the U.S., the leading cause of blindness and end-stage renal disease and renal failure is diabetes in our population. One of the complications that we see, the one that we're most concerned about with folks who have type 1 diabetes, is diabetic ketoacidosis, also known as DKA. So this is associated with type 1 or insulin-dependent diabetes mellitus. What happens is because we don't have that insulin to help us transport that glucose into cells to use for energy, your body then uses our fat stores as its form of energy fuel, okay? We're not used to that. So when we break down fat, we release ketones. It's an end product of our metabolism. Now we're using the fat, remember, because we have glucose, but we can't get it into our cells to use it. as those ketones build up in the body, it's going to lead to an acid-base imbalance, and that's going to be metabolic acidosis. These clients' blood sugars are going to go and climb up. They'll be over 250. And if we have a metabolic acidosis, our pH is going to be less than 7.35, and our bicarb, because it's metabolic, is going to be the other one we're going to look at, and that's going to be less than 15. If we examine their urine, we do a specimen test on it, we would see those ketones spilling over into their urine. So that would be a sign that they have diabetic ketoacidosis. The hyperglycemia is going to lead to a diuresis, which is going to cause dehydration because we're going to pull all that fluid out of our body and lose it. That's going to disturb our electrolytes, and we're going to have changes in our potassium level where we will actually get hyperkalemia. And remember, hyperkalemia can lead to some serious cardiac complications that we're very concerned about. So, because we lose the volume, your heart rate's going to go up to try and compensate, and you're going to get those small respirations because of the acidosis. That will be your body's way of trying to correct that acid-base balance. Now, type 2 diabetes, when we look at type 2, remember that's where we're going to have a relationship problem with our insulin and the need. So it's whenever we develop an insulin resistance in our tissues, and then we increase glucose production because we feel like we're not getting enough insulin, where it's really just floating around in our body instead of being used. This is more of an issue with the receptor sites that is supposed to pick up and receive the insulin and the glucose bonding and need to be used by the cell. It's also called non-insulin dependent diabetes mellitus, and this is the one that we have much more frequently. So it's the one that's related to obesity, diet, aging, inactivity, and even genetic factors. So with the insulin resistance, it's associated with a decreased number of those receptor sites. So since we have fewer receptor sites, we get less glucose transported into our cells, and then we have an increased production of glucagon. Whenever somebody is overweight or obese and inactive, these are things that actually increase our resistance to insulin. Your body's not active, it's not moving, it's not increasing its need for those receptor sites for that use of glucose as energy. So they atrophy, they become destroyed, and then they go away. So that's where you have the resistance, because those receptor sites are faulty. Our beta cells then are unable to produce enough insulin to meet the demand of all that extra insulin floating around, so we have an increased resistance. And then the decreased insulin production will go into play after time whenever your body starts to have mismatch between supply and demand with the receptor sites. Right. All of this is going to come into play and lead to hyperglycemia, which, remember, that is the high sugar content of your blood. So type 2 diabetes is 90 to 95% of our cases, right, in the U.S. So our major risk factors are a lot of things that are modifiable, but also non. So family history. If you have a family history, then there's nothing we can do. You're at increased risk. That would be non-modifiable. Race is also non-modifiable. So African Americans, Hispanics, American Indians, and Asian Americans are more likely to get type 2. And age. The older we are, the more likely we are to get it. Now, we can also have modifiable risk factors. So those are going to be things like obesity, sedentary lifestyle, and fat distribution. So when we look at fat distribution, people who tend to carry their weight more around the center of their body or their core, or have what they call an apple body shape, are at higher risk for developing type 2 diabetes than those who are more of a pear body shape, meaning that they carry their largest fat distribution around their hips and thighs instead. They too, with type 2 diabetes, get those classic diabetic symptoms of the increased thirstiness, the polydipsia, the increased hunger, the polyphagia, the increased urination or polyuria, and they tend to have more fluctuating blood sugar problems. They may also get itching in the skin, fatigue, vision changes, and burning sensations or paraphasias. They tend to be more obese than type 1 clients. And what we want to do is try and detect it early, because the earlier we detect it, the more likely we are to reduce our risk of having vascular neuropathy changes within clients. The major complication that we're concerned about with type 2 diabetes then is the hyperosmolar hyperglycemic non-ketotic syndrome, or HHNK. So this one's associated with type 2. Because we have some insulin and some receptor sites, okay, our body will still try and use that glucose first in order to make energy and metabolism. Unlike in DKA where they could not use it, so they use fat instead. So we still use some of that insulin. We're not going to use the fat and get the ketoacidosis like we did before. The problem with HHNK is that if they don't manage their blood glucose levels sufficiently, then their symptoms their levels can actually climb excessively high, so greater than 600, and they may not even have symptoms. The higher glucose serum level we get, that's going to increase our osmolality. Remember our concentration. You're going to end up with that higher osmolality in our plasma. It's going to pull that water out of the cells, and you're going to lead to complications like neurological symptoms and cerebral edema. When we look at diagnosis of diabetes, now these are all OR, so any one of these things could be used to help diagnose somebody as having diabetes mellitus. So the hemoglobin A1C is a blood level that what happens is that they will have an increase in their A1C level. It means that they're actually having an increase in their glucose level for the past few months. So it measures it over time, as opposed to the FPG, which is our fasting plasma glucose. So remember earlier whenever we talked about what after you eat and if you're not eating, what your glucose level would be. If your fasting glucose level is above 126 and you haven't eaten for 8 hours, then we would consider it a diabetic reading. A glucose tolerance test is where somebody would have to go to the lab. They drink a beverage that is very concentrated in glucose or sugar. They have to wait there for 2 hours, and at the end of 2 hours, they retest their glucose level, with the thought being is that they're going to challenge that pancreas, they're going to challenge that body systems to see if they can meet the demand of that increased level. Their level should return back down below 200. So if they don't, if they are above 200 after they have that sugary drink for 2 hours, then they would be diagnosed as type 2. The other way is if they have those symptoms, those classic symptoms of diabetes, and they get a random blood glucose reading and it's above 200. Alright, so what I'm going to do here is I'm going to stop this recording, and the next one we'll go over the chronic complications of diabetes mellitus for you.